Welcome to the bottom of the scrub bin. We are Lauren and Pam, nurses by training, pharma by accident, and moms by pure chaos. We've cleaned up the messes in hospitals, in drug safety, and in life, so now we're talking about them. Grab your coffee, your scrub top, or whatever's at the bottom of your own bin, because we're digging in. Hello, everyone. Welcome back to Bottom of the Scrub Bin. Grab your coffee and let's get started. Today, we're talking about a topic that I think a lot of people are going to feel in their bones, and that's medical gaslighting. Have you ever left a doctor's appointment feeling worse, not because of your symptoms, because you felt like no one actually believed you? We hear the term medical gaslighting everywhere now, on social media, in health conversations, in chronic illness communities, but what does it actually mean? Is it always intentional? And why does it happen so often?
Today, we're joined by Kimberly Bentley, a clinical research professional with over 10 years of experience across clinical trial operations, TF management, and site activation. Kimberly has worked across multiple phases of study startup and execution, bringing a strong understanding of what it takes to keep trials moving forward efficiently and compliantly. Outside of her professional role, she's also balancing a very full life at home. She's married to her high school sweetheart, Mike. Hey, Mike. And is raising two very active boys, which means she's fully in her baseball mom era and constantly on the go. Kim has also been my best friend for nearly 40 years, and that makes me feel really old. So, this is a really special conversation for me. Kim, I'm so glad to have you here.
Thank you both for having me.
Yes. So before we get into the heavy stuff, we're bringing back our recurring mugshot segment where our guests bring their favorite mug or whatever they like to drink out of and tell us about it. So, Kim, it's time for your mugshot. Tell us what you brought.
All right, so it's not a coffee mug, but it is a baseball tumbler. It's bedazzled.
Very sparkly.
It's
That thing is
bedazzled.
bejeweled.
Yes. And the comment I get when I'm checking in and paying my fee at the gate, because, you have to pay to get into these tournaments now, is, did you make that? Yeah. Did you make that? And I'm like, no, I didn't. No, I don't have time to make this.
Like, I was going to say, that's a lot of sparkles.
Yeah. It's all
That
the
would
way
be
around.
very time consuming.
Right.
Yes. I'm putting each sparkle on as I'm watching the ball game.
Yes.
And I'm sure that's just water watching all those games, right? There's nothing
absolutely.
special in
Absolutely. Yes.
There's
Nothing
nothing
more
special
needed,
in that
no.
mug.
At 8, let's see, what time are we getting there? 7:30 in the morning? Yes.
Yeah, right.
Strictly
right.
water.
Strictly.
Not a mimosa, no.
No.
Oh, I love it, Kim. So now that we know what's fueling this conversation, let's get into a topic that a lot of people know way too well, and that's medical gaslighting. So what is medical gaslighting really? I'll be the first one to raise my hand and say, I had no idea. But we hear this phrase everywhere now, and I think it means slightly different things to different people. For some people, it's feeling dismissed. For others, it's being told their symptoms are just stress or just anxiety. And for some, it's years of being told nothing's wrong before finally getting an answer. So before we jump into our stories, I think it makes sense to start here. When you hear the phrase medical gaslighting, what does it mean to you?
So I think this is such a sticky topic because it can mean many different things, in my opinion. Sometimes I think it can be, like you said, dismissed, where someone goes in for the same symptoms over and over and they're told, oh, everything looks fine, instead of looking into the possibility of something else actually going on.
Right.
Or their symptoms are minimized and they're told, oh, this is pretty common or this isn't that serious, without even looking into the seriousness of that situation.
Mm-hmm.
Sometimes the blame, I think, is shifted back to the patient because of their lifestyle. And even though they have physical symptoms, it's immediately labeled as anxiety or stress without even looking or ruling out other things first.
Right.
I think this is an important one because it's when a provider genuinely does not know a diagnosis yet. Medicine is so complex. Not every symptom has a clear answer right away. Or maybe there isn't
exactly.
enough symptoms that present a diagnosis yet.
Mm-hmm.
The difference to me is whether the provider keeps investigating or are they going to shut it down?
Right.
So,
Yeah.
and lastly, the true line that crosses into medical gaslighting is when someone is made to feel like what they're experiencing is not real.
Yeah, like
You
they're
know, this
making
is
up
when
in their head. Right.
right. So like you said, I mean, it's when a patient starts to question themselves, like,
Mhm.
well, am I overreacting? Am I
Mhm.
crazy? Even though something is clearly wrong, and doing this over and over to patients can delay diagnosis.
Yeah.
I think the difference in all of the above that we just mentioned, or I just mentioned, is a healthcare provider that will sit with you and say, I hear you, I see you, I don't have an answer yet, but let's keep
Mhm.
looking into this versus just shutting the patient down.
Exactly. Yeah.
Yeah, and I think, from my perspective, medical gaslighting is less about a misdiagnosis and more about how you're made to feel. You're not being heard, or what you're saying doesn't matter, or somehow you're the problem instead of something being wrong with you.
Right. And it may not be intentional, but you sure as heck internalize that.
Right. Lauren, do you think the term is overused now, or do you think it's finally giving language to something people have experienced for a long time and we're just now saying it?
I think it's probably a bit of both, honestly. Any term that catches on can start being used more broadly than intended, but I also think it's finally giving people language or a word for something that a lot of people have felt for a long time. That's a sense of, I know something's wrong, but I don't feel fully heard, kind of like Kim said. That doesn't mean every difficult healthcare interaction is gaslighting, and it doesn't mean clinicians are out there actively trying to dismiss
Right.
people. I think a lot of the times it's pressure, it's limited time during the appointment, it's quick assumptions, or just missing the mark in terms of communication. But the patient experience is still real. So I think if the term helps people name that experience and talk about it and get it out there, I think that matters, because we can't improve something until people don't even feel like they're allowed to talk about it or describe it.
Agree. Kim, why do you think this topic has exploded so much online?
I think a big reason the topic's exploded online is because we're constantly on our phones watching reels, videos, TikToks, and we're seeing other people share their experiences that feel familiar. There's comfort in realizing you're not the only one. And once one person speaks up, it makes others feel safe to do the same. And unfortunately, a lot of people feel like they must turn to their own research and resources to find answers when they're not getting them elsewhere.
Right. Which can be a blessing and a curse, right?
Yes,
Exactly.
exactly. Exactly. I Dr. Googled this, and this is what I have.
Right. Dr. Google told me. Right.
Pam, do you think a provider can unintentionally gaslight a patient?
Well, I don't think most providers are purposely trying to gaslight their patients, right? I mean, most providers went to school that long. I mean, that's a long time to go to school to care for people. But
Exactly.
it can absolutely happen unintentionally. For example, if labs come back normal and a doctor's running behind that day, he may say, well, everything looks good, come back if it gets worse. And the patient at that moment may go, okay, thanks. And then they walk out, they get in their car and they go, well, wait a minute, I don't have an answer. So
What
what's
just
the next
happened?
step? Right.
Yeah.
Done
So,
that.
if a patient walks away feeling unheard or questioning their own symptoms, that's where, the problem starts.
Yeah. I don't think the intent is usually just to dismiss someone, but like you said, if a patient leaves feeling unheard, that still matters.
Right. And I think that's the part people don't always talk about, because most providers aren't trying to purposely dismiss patients, but something is happening in the system that leads people to feeling that way. So let's get into that part, why this actually happens in healthcare. This is where I think our nursing background really comes into play, Lauren, because there are so many reasons why patients walk away feeling unheard,
Absolutely.
even when nothing was technically missed, but something still didn't get fully addressed. So, going back to our episode 2, when we talk about short appointment times, those 10 to 15-minute visits don't allow for time to really dig into what's going on.
Right.
I know when I go into a visit now, I'll actually have my notes in my phone and I basically talk in bullet points. I'll be like, I had a headache, started 2 weeks ago, started taking Advil, helps a little, started sinus pressure 1 week ago, started decongestant with minimal relief, no new medications, nasal sprays, no fever. And I talk in bullet points just to quickly get everything I want in a short time.
Yeah, it's like you're up
And I
against
know
the
they're
clock. Tick,
right.
go.
I'm like, watching that clock. I got to get everything out. So, anyways, also on the nurses and the doctor side, burnout is a real thing. We as nurses have experienced this, but when you see patient after patient, it's hard to really slow down and fully engage. And if you're behind, you can't stop thinking about,
Yeah.
what
What's
you
ahead
have
of
to
you.
get done, what's going on next door for that next patient. And
Right.
that's not fair to the patients, but it's a reality.
Yeah.
Another one is early assumptions. And I've seen this, I've experienced this, is when a provider hears the first few symptoms when you're talking and they quickly decide what it is. So then everything after that is kind of ignored. And I think sometimes as a patient, you can see when this happens, right, in that visit, because the provider, you're in the middle of talking, that provider starts nodding their head. And sometimes they'll even interrupt you and start talking about what they think it is. And it's like, no, wait a minute, I'm not done talking here, you know? So,
And I don't know about you, but sometimes I'm a little hesitant to speak up and advocate for myself at that point because I'm like, well, they're the one that went to school for 30 years,
right.
They are the ones that know their stuff. Who am I?
Right.
So I just sit there and I'm like,
oh, okay. Right.
until I leave the
know.
appointment. And then I'm like, oh, wait.
I should have said this or I should have said that. Right.
Mhm.
Right. And I think some providers have a heavy over reliance on labs or normal tests. And usually these are the initial basic testing is what I'm referring to. So it's one thing to say, hey, these tests are normal, so let's look at something else. Let's keep digging versus, well, your tests are normal. You're just stressed. You have anxiety. Come back if it gets worse. The handoffs between providers is another issue. If one provider forgets to document something or mention something in transition, then the new provider may come on and assume it wasn't a priority or they forget something and things kind of fall through the cracks there.
Another example is if, you go to an urgent care instead of your primary care physician, your PCP or primary care physician may not have all the documentation and notes from that urgent care visit. So,
and that goes into that goes into my next one is the fragmented care. That's a big one. I've experienced this myself and with family members recently. Like you said, you have a primary care or then you have one or more specialists and they aren't all communicating, so the dots are not aligning. And so this can create confusion for your healthcare providers and the patient as well. So you have one doctor saying one thing and then you have another doctor telling you something else. And some of this goes back to not all of them being on the same portal. So communication in multiple different places, you know?
Yep.
And so insurance, Lauren and I, Kim, we always talk about insurance. This one plays a big part, more than people realize. Providers know from experience what tests will be approved, what tests will be denied, or cost a fortune for the patient, and diagnostics and treatment might get delayed for that reason. And I think we need to fix this issue. And insurance companies need to be held accountable. This is getting out of hand, if you ask me. And if my doctor thinks that I need an MRI of my spine, then an insurance company should not be or have the right to deny that. So that's just my opinion, my 2 cents. I'll just throw that out there.
Yeah. And sometimes when doctors don't order, a slew of specific tests, it may not be that they're dismissing you per se, but they're taking into account the cost of those diagnostic tests or lab tests. And they're trying to keep your best interest at heart while trying to get to the bottom of the diagnosis. So it's kind of like give and take in terms of getting you the best care, but being mindful of cost and keeping your best interests at heart as well.
Right. I had mentioned the MRI of the spine as an example, and that's because that's exactly what happened to me is I had a neurosurgeon say, well, I want to do this MRI of your spine, cervical spine, but we have to get it approved by insurance first, and it may not be approved or so you may have to pay out of pocket. So I was just like, well, just do it. If I have to pay out of pocket, I'll pay out of pocket. But he did give me that option. So anyways, but
and then you also have sorry to interrupt there, but
Go
you
ahead.
also
No,
have
yeah.
where you've gotten a test done and you get the bill and you're like, oh, shoot, that's expensive.
Yeah.
I can't do any more tests right now.
Right.
So you kind
Yes.
of push yourself off and say, well, I'll just get it next time, or next time it flares up, I'll go in and get that test done.
Yeah.
Yeah, that's a reality. Yes, agree. Sometimes it's just the pressure to keep moving and to get to that next patient, the
Yes.
timing.
Yes.
So it can affect the time and attention someone gets when you layer all of the above together. It doesn't excuse it all, but it does give some insight as to why we can sometimes walk away feeling unheard.
Yeah, absolutely. And I think healthcare is often really good at ruling out the big scary stuff like heart attacks or multiple sclerosis as examples, because obviously, those big deals, those big scary things do matter. But sometimes once those things are ruled out, the conversation kind of ends there. And for the patient, that doesn't always feel like a relief because they still don't feel well. They're still worried. They still want to understand what's going on.
Yeah, and I think we have all this new technology, which is great. I mean, we're discovering, different diseases and illnesses quicker than what we would have in the past. But I also think it delays our ability to listen to the patient. So sometimes we just need to stop and listen and not let's plug these into our handy dandy notebook and see what pops up instead of just,
Right.
sitting with
Yes.
and getting the full picture. Like, I hear you, I see you. I will write everything down and we will go step by step through each symptom.
Right. Even if the doctor has to take it back, I'm okay with
Yeah.
that too.
One
ahead,
thing that I
Lauren.
really like that my primary care physician started doing is using a recording device with my permission to record the actual visit. And I feel with the use of that device, I am heard because, every single thing I say during that visit is documented. So at any point in time, she can go back and listen to the conversation we had in case, due to the rushed appointment time, she was just grasping at the most important details that I was throwing out there, but she can get into the nitty gritty should she want to go back and listen to that full recording the latter time.
I love that idea, actually. I'd be fine with them going back later, if they didn't have an answer, listening to what we had and doing their
Yeah.
research. I'd be okay with that.
Yeah. It helped me feel heard just by using a simple tool like that.
Yeah, I like that. So how much of this is the individual provider and how much of it is the system?
Again, I think it's a little bit of both, but probably more system than the individual provider. I think most clinicians are not walking into the room trying to dismiss anyone. And I think they most genuinely care. Again, like we said earlier, I mean, they've gone to 30 years of school for this to take care of patients. So I think they genuinely care. But healthcare is built around, speed. It's built around triage and it's built around ruling out the dangerous things first. And that's important. But the hard part is that once those big, scary things, again, are ruled out, the system doesn't always leave a lot of room for the rest of the story. So what gets missed isn't always the diagnosis. Sometimes it's the context or the nuance of the symptoms, or just how much the symptoms are actually affecting a person's day-to-day life and their activities. And I think good clinicians can miss what's right in front of their face for very human reasons. Like we've touched on, the time pressure of the appointments, pattern recognition, because they may not get the whole story from the patient, cognitive overload, and the pressure just to keep moving so that they can see X amount of patients in the day. And sometimes I think this leaves the patient thinking, okay, maybe this isn't emergent or very serious, but I still don't feel okay. And I still don't understand why I feel this way.
Right. Kim, do you think women are especially vulnerable to being dismissed because of how we're socialized or how symptoms are perceived?
I do think that to an extent, just some of the medical field previously being more male dominant from my, perspective, I've had a lot of male doctors versus female doctors. And then it wasn't until recently that they've all kind of switched over. But I also think it's just how we're perceived. It's quick to go to anxiety or stress, or it's hormones. It's a lot of things that get labeled as common, but that doesn't mean they're normal and they shouldn't be ignored.
Right. And I think until recently, you mentioned the hormones. I think we're now starting to see maybe a little more direction in that and how to treat that.
Yeah, I
So
think
that's a
people are
good thing.
talking about it more.
Mm-hmm. Right.
Well, and you have to think, my mom never talked to me about any of this stuff. And I don't think her mom did
Taboo.
either, right? Yeah, you didn't bring up your symptoms coming from my parents' perspective.
You just
So-
always wonder why your mom was pulling the shirt off because she's hot.
Turning
Yeah.
red and sweating in an instant. Yeah.
What is wrong with you?
That's right. Why is my soap on the floor all of a sudden a problem? Like, what is going on? So I think, our generation is saying, no, we're not going to take no for an answer, or no, we're not going to be dismissed. We want to be heard and understood, and we want this problem solved.
Right.
Absolutely. And, on top of the hormones too, mental health. That's another one that I think is starting to creep into the medical scene and that we're talking a lot more about.
Like it used to be taboo and it's not
Yeah.
anymore, just like the hormones. Right.
Pam, in your opinion, does healthcare sometime overvalue what can be measured in a lab over what the patient is clearly telling you?
I think so. I mean, I think it goes back to what you said earlier about ruling out the most serious thing first, because basic labs are ordered to kind of rule out those life-threatening issues, and then they come back normal and it becomes a stopping point. And normal labs shouldn't be the end of the story. They should help guide, what we're looking at next in that patient so we can figure out what's going on.
Yeah. And I think when all those pressures stack up and there are certain conditions and honestly certain groups of patient, we all hear the same stories over and over again. There are definitely certain patterns we keep hearing again and again. It's things like endometriosis or autoimmune diseases, thyroid issues, chronic pain or fibromyalgia, GI symptoms that kind of just get brushed off as stress, or like we touched on a little bit ago, hormone-related changes like perimenopause or menopause, and symptoms that don't always fit the typical or expected picture. And I think, honestly, one of the biggest things underneath all of it is when anxiety gets brought in too early. Not that anxiety isn't real, because it absolutely is, but sometimes once that label enters the conversation, it can kind of overshadow the fact that something physical or something else may be going on as well.
Right. Like what's causing the anxiety?
Yes.
Is it truly just anxiety, or is there an underlying condition that's maybe causing it?
Right. Instead of just throwing a blanket on top of it.
And what's frustrating is this isn't just a one-off story. You hear it again and again. You hear it from women, from men. Everyone's saying, I knew something was wrong, or I kept getting told it was stress. I started second guessing myself. And then later, something actually shows up, and whatever that is had to get worse before there was a diagnosis.
Right.
And I know it can happen to anyone, but we do see it more often in women, especially when symptoms aren't straight from a textbook. There's data showing women are more likely to have symptoms dismissed or attributed to things like anxiety and stress, but it's not exclusive to women. It can happen to anyone.
Right. An example of that would be myocardial infarction or heart attack. In women, the symptoms are so vague and can vary from person to person. So in one instance, it could be perceived as a panic attack, a mild panic attack, because you're having chest tightness, or acid reflux because you're having pain in your jaw. But until they look into that deeper, you don't know if the patient's actually having a more serious event like a myocardial infarction.
Yeah, and how many times have you looked on the news or Instagram and seen the stories of, well, I thought I just had a headache, but now it's actually stage 2 cancer or some tumor or something like that. So, I think we're just getting it more known out there, which is great.
Right. And hopefully that'll keep happening. And instead of waiting until things get worse before we start taking patients seriously, we can catch those earlier. Lauren, what kind of stories do you feel like we hear over and over again?
I think one in particular is someone who had ongoing symptoms, maybe fatigue or pain, or just this general feeling that something is off or isn't right. And again, once the big dangerous things are ruled out, they're told, oh, everything looks great. Everything looks okay. But again, they're still sitting there thinking, okay, but I don't feel okay. And I think it's this space between the non-emergent and actually getting answers or feeling better is where a lot of the people start to feel dismissed.
Agreed.
And Pam, have you ever started second guessing yourself because someone in healthcare made you feel like you were overreacting during an appointment?
I mean, which story should I tell? No. Actually, the biggest one for me is I had a pretty bad reaction to a particular vaccine. A few days after having it, I was really weak in my legs and my arms. I had nerve pain all over my body. I could barely lift my coffee mug without it shaking like crazy.
Goodness.
So I actually went to a neurosurgeon who is a friend of ours, and he did an MRI of my neck. He just wanted to rule out I didn't do anything to my cervical spine. And
Yeah.
it was normal. And he basically was like, look, you need to go be seen by a neurologist. So I went to my first neurology appointment, and it was an older gentleman. He walked in, did not even look at me, put his computer down, and he goes, I have a daughter your age, and she is so stressed. And let me tell you what stress can do to your body. And at that moment, I just shut down.
Yeah.
I was like, he did ask me to walk 5 steps in his office, back and forth. And he's like, well, you're walking fine. And that was it. He chalked it up to stress and anxiety in my life at that moment, and did the whole come back if it gets worse. I then got a second opinion at another neurologist who was a little bit better. He ordered an MRI of my brain. He did a few neuro tests, and he also asked me to walk 10 steps in the office back and forth. And later on, the MRI came back normal, and he's like, well, you don't have MS. And that was it. There was nothing like, well, let's do more lab
For the
work.
next steps. Yeah.
Let's keep looking. He did tell me about stress management. He told me, he's like, well, you need to get 2 to 3 massages a month, and you need to take care of yourself.
Did you tell my husband?
Right. Does insurance pay for those? Really. So finally, I did get a year and a half later an answer from rheumatologist. Well, kind of an answer. He finally did admit that it could have been the vaccine, related to the vaccine based off timing and symptoms and all that.
Yeah, I've actually had my own experience, not quite similar to that, but I think that's part of why this whole topic feels personal to me. For years, I had been going to different providers for fatigue, poor sleep, episodes of depression that seemed to come and go. I saw a great primary care physician, my OBGYN, mental health care professionals. I had all the lab work done, thyroid, iron, CBC, vitamins, all of it. And everything kept coming back normal. And at one point, I was diagnosed with generalized anxiety and treated, but even with that, things didn't really improve. And then after a while, I started doing what I think a lot of people do. I started questioning myself. I thought, well, maybe I'm overreacting. Maybe I'm making too much of this. Maybe this is just normal part of life and I'm being a wuss and I need to learn how to deal with it.
It's that self-doubt again.
Yeah. Yeah. But what finally changed things was that I started tracking my symptoms and I realized there was a very clear monthly pattern with my symptoms. And when I brought that forward to my mental health provider, she recognized pretty quickly that what I was describing was very consistent with PMDD or premenstrual dysphoric disorder. And she connected me with my other doctors and I was started on the right treatment. And that right there made a huge difference. So for me, the biggest takeaway is that I'm really glad I kept paying attention to the pattern and really glad that I kept advocating for myself because it wasn't all in my mind. I wasn't just making it up. I wasn't crazy. It just hadn't been clearly identified yet.
That's so frustrating when you have to, it goes back to there's the generalized anxiety, just the staple, the blanket, here you go.
Right.
But I'm glad you finally got an answer.
Yeah, me too. And my husband.
Right.
When you said, Lauren, you said that you started tracking the patterns. Like,
Yes.
did the doctor ever ask you to track anything, or were you like, I need to start tracking this?
They did not,
Yeah.
but I think that's where my nursing training came in to, write everything down, journal
Yeah.
it, document it. And I don't really know why I didn't think of that before, but something clicked. I was like, you know what? I'm just going to start tracking these symptoms of when I get, irritable or depressed. And
I think sometimes that brings up a good point, that when you take the initiative to do that stuff and you go in there, sometimes in that initial visit, they'll say, well, go track things. So then now you've got to go home and track things and then come back for another visit. So maybe that will eliminate that first initial visit and you already have these answers, so the doctors can't send you back home.
right, be proactive in
Mhm.
documenting your symptoms.
Right. I know. I had I actually started to lose my hair very quickly. I think it was last year, 2 years ago. I don't even remember. And went to the dermatologist and they took a sample of my hair and came back and said, well, this is just normal female pattern hair loss. So my common sense kicked in, and because losing clumps of hair was not normal. It was not normal female pattern hair loss. So I went back and it was a male doctor, and he goes, well, just use an organic shampoo and you can try minoxidil. And so I expressed my concern and I was worried. I mean, I was to the point, I was like, do I need to start looking at wigs?
Yeah.
And he looked at me like I was crazy. And he was like, look, there is nothing I can do, but you can try these things. So I had to go and find my own shampoo that actually kind of helps with hair loss. Um, I looked up vitamins, hair oils, because there was more than just organic shampoo and minoxidil to add to my regimen. So he made me feel as though I was being ridiculous. But hair falling out for a woman is
It's
a
a big
big
deal.
deal.
Yeah.
Right. Hair for women is important.
It's part of
Not
your
that it's not
identity
for men, but it
as a
is. It's a
woman.
part of your
Yeah.
identity. And I hate to sit here and complain, because I know there's people who are taking chemo who have to lose their hair. They don't have an option. So I feel guilty even complaining. But, it's just, it's a big deal for women.
Well, and
Yeah.
I've been blowing you up lately because I'm kind of dealing with the same thing. Like, okay, what shampoo did you use? What vitamins did you take? What mask are you using? I think we all go through that. And so it's been helpful to have you, unfortunately, who went through it.
Well, so to ask you this then, Kim, did you come and ask me because in your mind you felt, well, if I go to a doctor, I'm just probably not going to get an answer, so I'll just ask my friend who's been through it? Because I kind of feel like that's a thing too now, right?
I think so. Because, I have hypothyroidism. So if I go in there and say, well, my hair's falling out, they're like, oh, well, it's because you have hypo. And I'm like,
Yeah, they just chalk it up to
no,
that.
I don't think that's all of it. And so,
I've had this for
my
years. Right.
Yeah, and I tell Mike all the time, I'm like, okay, I'm gonna text Dr. Reeves and see what I can get from her, like, because I got her on speed dial.
Yeah.
And Kim always starts the text too. Like usually we text like all the time, but then I know it's a medical question because she'll be like, hey, Dr. Reeves. And, and to clarify, I'm not a doctor. She just calls me that.
She is not, but she's the closest thing to me that I have that's a doctor, and will give me the straight up answer like, no, you're crazy. Don't do that. Or here's what I've tried. Don't waste your money on this, that, and the other. So,
Right.
yeah.
Or why did you ask Dr. Google?
That's right. Well, and that brings up a story I have is, like I said, I have hypothyroidism. So a lot of my symptoms overlap and can be hard to pinpoint exactly what's going on. And I'll go in and say, here's what I'm feeling. I think it could be this or that. And sometimes I'll hear, I'm not sure. I'll make a note and get back to you if I find anything out. And I never hear back. And I'm like, well, a call to say, look, I'm sorry. I looked into it. I can't come up with anything. I would take it. But to just be dismissed and not hear a response,
I'm going to get back to you.
Yeah. You're just looking
so
for
frustrating.
some type of validation or closure.
Yep.
And even
Just
a short
something.
email, I know they're very busy, but even a short email can help in that situation.
Exactly.
Because I think if you're constantly dismissed, a lot of us tend to minimize our symptoms before the appointment even starts.
Right. And honestly, that self-doubt part is huge. When someone starts second guessing themselves, like, well, maybe it's nothing, or maybe I am overreacting when something is actually going on. And this becomes a problem when someone is having a medical crisis or maybe even a life-threatening issue, and they don't want to be seen because so many times before they were dismissed or their symptoms were minimized. So now they naturally just do it themselves. And that's what it actually feels like on the patient side, which is what I want to go into next. The emotional toll it takes on a patient is so real. When you continue to be dismissed, symptoms are minimized, and the longer you go without some kind of answers, you start to have all these internal feelings. And you start to have anxiety because you constantly wonder what is wrong with you. Or, of course, most women that I know, and Kim makes fun of me all the time, is that we go to the worst possible scenario. And Lauren, you know that too. I'm like, Lauren, I got a headache. It's brain tumor.
No.
So
Not me.
Have you
And-
talked to my husband? He's the same way.
oh yeah. So
The kid
and
is
Kim's
sick.
always like,
oh, I have
"You're
to
fine."
Yeah.
I have a headache. It's a brain tumor. Like, that's where I
Right.
go.
I know, it's always worst case. So, but then, the shame you feel because you start to wonder, like, maybe this is a bigger deal than what I thought. The self-doubt you mentioned earlier, and then feeling difficult when you're in those appointments because you're asking questions and maybe it comes across as you being a little bit challenging to the provider, when in reality, you're just advocating for yourself. And the biggest one for me, and I hate this word, I cannot stand it, especially when I truly have symptoms, is the feeling of being dramatic or like even talking about the issues. All of these can wear on you over time. And that's how people end up minimizing their own symptoms before they even walk into the appointment.
Yeah, that's real. And I think that lands. And I think that's why it lands so deeply for a lot of people out there. Healthcare feels different because there's so much trust built into that interaction between the patient and the doctor. And when you walk into those appointments, you're already vulnerable, you're already worried, and you're looking for answers. So if you leave feeling like your concerns didn't fully land with the provider, that can be really impactful.
Yeah, and just minimizing your symptoms before, because you say to them, who will think or listen to what I have to say, or, oh, it's nothing. And then, well, to me, it's something. Like I'm feeling it daily or multiple times throughout the day, and to just have them pushed aside.
I don't know if this resonates with either one of you, but I'll sit at home debating whether or not to go to the doctor for a particular illness. And I will wait until I am sick as a dog because I don't think I'll be taken seriously by the healthcare provider, or, oh, it's nothing. And I just wasted their time and mine. So
You wait until you have the undeniable symptoms. Like, there's no way they're not going to see this now.
Yes.
And you mentioned trust earlier, and Kim, I'll kind of ask you this one, but Lauren and I have that medical background. We've been, we went to nursing school, we worked in nursing. So a lot of times we go in, and if we feel like we're getting maybe dismissed or minimized or something doesn't sound right, that healthcare part of our brain kicks in and we go, I don't really trust what they're saying. But do you feel like as a patient, and you do work in the medical field, you work in good
different
clinical
side.
research, right?
Yeah.
A different side, clinical research. But as a patient, do you sometimes find yourself while you're in that appointment trusting what he says because he's speaking or she is speaking with such confidence? And you're like, and then when you leave, you're kind of like, no, wait a minute.
Like, what?
Oh, absolutely. Yes. How many times have I sat in the car and I've thought, okay, yeah, like they know what they're talking about. I do not. Like we said before, they went to school forever. So maybe what I'm saying isn't correct. And so you are being gaslit, right? So I mean, you definitely doubt yourself when you feel someone who has a better understanding knows the topic and you don't.
Yeah.
Right. Lauren, why do you think being dismissed in a medical setting hits so differently?
I think it lands so deeply because the setting matters. If someone dismisses you in everyday life, it stings. But I think in healthcare, you're usually, like I said earlier, already walking in worried, vulnerable, and, wanting answers. For example, imagine someone has been dealing with ongoing symptoms, fatigue, GI issues, and they finally work up the courage to go in, maybe after putting it off because they don't want to seem dramatic. The big scary things get ruled out, which is obviously important, but then the visit kind of ends there. And the provider may be thinking, yay, good news, this isn't an emergency. But at the same time, the patient walks out thinking, okay, but I still feel awful and I don't know what's going on and I don't know what's wrong with me. And again, that gap between you're not in imminent danger and I actually feel heard and know what the next steps are, that's where this gets really sticky. And that's what lands with a lot of people.
Right. It's the difference between let's keep looking versus just stopping because we've.
Exactly. And have you ever felt guilty for asking more answers during an appointment?
I would say when I was younger, yes, but I think working in the medical field on both sides, and then especially after 40, because I just don't care about anything anymore.
We do not care club.
Yeah, I don't care. We are in the we do not care club. Yeah. Like, I don't have an issue feeling guilty anymore. Like I said, I try to go in prepared with my symptoms and questions just to kind of maybe help that provider. Does it help? Maybe they order 1 or 2 more tests, but in the end, I still end up getting the professional form of I don't know, which is, if it gets worse, come back and see me.
Yeah.
Or, here, let me refer you to someone else. And then that person refers you to someone else. But as far as the guilt, not anymore. I think we have to get rid of that in order to get the answers that we need.
Yeah, I think more so than guilt, in my personal experience, is somewhat of an imposter syndrome. I'm very much an introvert, and sitting there in front of the doctor who has had 30 years of training, I wouldn't say feel guilty, but I'm hesitant to ask more questions. I'm hesitant to kind of pry and ask for further steps. And I think that's where I personally need to improve. I need to advocate for myself and I need to stick up and kind of get rid of that imposter syndrome.
Yes.
And
Agreed.
Kim, why do you think so many patients end up, provider shopping? Not because they want attention, but because they're desperate to be heard and desperate to get some answers.
I think a lot of it comes down to people just wanting to feel heard, like you said. When they don't get that, they keep looking until someone listens and take them seriously. I had a situation where I was still on birth control until probably 6 months ago. And I said to an OBG, like, I'm feeling these symptoms. Could they be perimenopause? And she looked at me and said, you're too young. The average age is 50. Bye. See you next year. And I looked like deer in headlights. Like, oh, okay, that's what we're doing.
I think so many of us have been there, yeah.
Yes. So instead of sitting down and saying, let's see what your experience, let's see if it's a possibility, I have since switched OBs, and this new one said to me, you're still on birth control. Let's get you off. Clear your system for 3 months. Let's run some tests. Let's see what they say. If they say nothing, great. If they say something, we'll start from there. And sure enough, they weren't fully blown indicators that I was on. Said you're elevated here and there. And so yes, your symptoms I think are valid. And I wanted to cry. I wanted to hug her. I wanted to run around the office screaming because someone finally heard me.
Validated.
Yes, I was so excited to have her. And so yes, she's my OB.
That's awesome. And I think that's what makes this such a layered conversation, because a lot of what we're talking about here isn't always intentional or malicious, but that doesn't mean that it still doesn't leave a mark, especially like in your situation, Kim. And as nurses, and Kim from your side too, we also understand that there is another side of the room here. And I think it's important for us to talk about that honestly as well. Speaking of the providers, they're trained to triage risk very quickly. So they're juggling patient volume. I mean, they're seeing patients every 10 to 20 minutes for 8 hours every day. On top of that, they're having to chart everything within the 8 hours or into the late night. they have to take into consideration liability. Sometimes they get incomplete records or they don't get records at all if, say, a patient goes to urgent care or an ER or sees a specialist. There's also productivity pressure, especially in private practice, and then time constraints with those appointment times. And that often leads to not enough patient support. And sometimes what sounds like dismissive during an appointment may actually be rushed communication or poor phrasing, maybe false reassurance, or just the inability to explain uncertainty very well to your patient.
Yeah, and that's where that gets sticky, right? So because this still affects the patient no matter what. But there is a big difference between the provider not knowing, time constraints, and communication gaps versus making someone feel dismissed. And this is where intent and impact don't always align.
Yeah, and I mean, at the end of the day, even if it's not intentional, the feeling of being dismissed is still real for the patient. And that's what makes this such a hard line to navigate.
Yep.
So, Pam, I'm going to ask you, how can providers say, I don't know yet, without making patients feel dismissed? I know I've heard this plenty of times at appointments. And so just what do you think we could take back?
And this is all my opinion, right? So I would much rather a provider tell me, these labs or diagnostics are normal, but I can see that you're still having these symptoms. So let's see if we can do something more. Let's keep digging. That's so much better to me than we'll come back if it doesn't get any better. If you don't have an answer, that's fine. We're all human beings and things are not always clear like a textbook. And Lauren and I learned that when we got out of nursing school. But until you have a solid answer, keep digging. Use the degree. I mean, you went to school for a long time. Lauren, how do you validate symptoms without overpromising answers?
I think the key is that validation doesn't have to mean absolute certainty. You don't have to immediately know what's causing the symptom to make someone feel heard. Kind of like you said, if someone comes in with dizziness and a headache and the first round of tests doesn't show anything dangerous, you don't have to jump to everything's fine, you're good to go. Call me if it doesn't improve. You can say something like, I'm really glad we're not seeing anything emergent right now, but that doesn't mean what you're feeling isn't real. I can tell this is affecting your day to day. So let's talk about what next steps look like. And that way you're being honest, but you're also not making the person feel like the normal test result means the conversation is over.
I think a lot of people feel like they have to answer right away. The pause or the unknown is not comfortable with them. And so sometimes I think doctors just want to answer without pushing the patient off.
Right. Yeah. And in your opinion, Kim, do you think that providers sometimes unintentionally use language that sounds far more dismissive than they may realize? I know I'm a very dry and blunt individual, and sometimes I may not realize what my face is conveying or that my comments may lack some empathy.
I don't know what you're talking about.
Fix your face.
Right. Don't look at this. I do think they can come across as dismissive sometimes. They see so many patients every day, like you've said previously, and there's so much information to keep up with. Medicine is always changing, and so we expect them to have all the answers right away. But they're learning new things too. From the patient side, though, we're only focused on our own symptoms. And so when we don't get an answer, it can feel dismissive, even if that's not the intent. So how many studies have you seen recently? And I think Pam and I talked about one at dinner the other night where about melatonin. Previously you weren't supposed to take it. It's going to create this whole disruption of your natural melatonin. Well, now you can take it. It's okay. And then in a couple years, they'll say, don't take it. We were just kidding.
Yeah.
So, doctors have to keep up with all of that too.
Yeah. It's always evolving. And I remember someone saying to me a long time ago, it's called practicing medicine for a reason. It's not absolute. It's always changing. And so you constantly practice to get better at diagnosing patients.
Oh, I like that.
Yeah, deal with the ever-changing research.
Yes, because it does change every few
Yeah,
few
it
years, which
does.
is why we wait
Yes.
after a drug's approved to take it. No, so anyways, so if we know all this happens and we know it's often a mix of human error, system pressure, and a communication breakdown, the next question becomes, what can people actually do when they're in that moment? How can they advocate for themselves?
Mm-hmm.
And this is the part I hope people really take notes and get something helpful from this episode. Because while patients shouldn't have to and aren't able to do all the work, there are ways to advocate for yourself that can help keep the conversation moving and maybe not be dismissed or shut down so quickly.
Yeah, and I think we've talked or touched on this a little bit throughout the episode. I feel like there are a lot of really practical ways patients can advocate for themselves without it feeling confrontational. And I don't think anyone intentionally wants to rock the boat out there. I think things like tracking symptoms, bringing notes, or a simple timeline, writing down what triggered your symptoms or how severe they are and what makes them better or worse. I think it can also help to ask the questions like, well, what else could this be? Or if this doesn't improve, what are the next steps? You can always ask for a follow up plan or bring a support person if you need one to your appointment. And don't be afraid to get a second opinion. Don't feel guilty about getting a second opinion if your gut is telling you to go visit another provider. And none of that means you're being difficult. It just means that you're helping make sure the full picture is being seen.
That's right. And how many times have you gone into the appointment and they ask a question and you say, I can't remember when this started or what day was that? Because I know I say to my son, well, it's my mom brain. I have no idea. Because he'll ask me, well, was that yesterday you did that? And Ethan, I don't know. It could have been today.
Yeah.
So if your brain's as scattered as mine, you're sitting in that appointment thinking, was that Tuesday of last week? Wednesday of this week?
And I think that's where writing it down or keeping a journal would really help because it would rule out that ambiguity or the vagueness of the symptoms and kind of really nail it down for the
I think
provider.
Right. I think we keep coming back to that. And this is probably the second, maybe even third episode we've discussed, like going into that appointment, having that list, being prepared, because now we've got another reason why you should, right? It's not
Right.
just about helping those doctors get through, like we mentioned in episode 2, so you don't have to sit in that waiting room so long. You're kind of helping them move along. You're also helping them come up with an answer because like I mentioned earlier, you go into that initial appointment, they're probably going to go home and tell you to write this down, keep a log,
Yep.
and then come back. So now you're eliminating an extra doctor's appointment for that.
Yep.
So, Lauren, what's one thing you wish more people knew before going into an appointment?
Honestly, I wish more people knew that before an appointment, it helps to think through the pattern. So, kind of like what we just touched on, not just the symptom. As I touched on earlier with my PMDD diagnosis, I noted what's been happening. I noted for how long, how often, what had changed, and how it was actually affecting my day to day activity. Because saying something like, oh, I'm just tired, that's one thing. And that may be very vague, but saying, oh, over the course of the last month, I've been so exhausted. I'm falling asleep on the couch after work. I can't get back up. I can't exercise. I'm getting lightheaded and I can't do what I normally do. I think that level of detail is much easier for a provider to really understand quickly, especially in a condensed appointment time. And in a short visit, that can make a huge difference.
Right. And I feel like just over the years, that is probably the one question that they do come back with. Kim, I don't know if you agree, but they always come back when you say a symptom. They're like, well, what triggers it? Where does it start? What's the timing?
Yeah.
So go ahead and have that information ready.
Yeah.
That's right. Be prepared. And so, Pam, from your perspective, what's one phrase patients can use that helps them advocate without feeling confrontational?
I would say that if the provider tries to dismiss you without some kind of answers or doesn't want to look further into what's going on, say something like, I understand the need to continue monitoring this at home. but I still have these symptoms. So is there anything we can do now or other tests we can run, to get closer to getting an answer?
Mhm.
So you can also add to that. I understand for my own records, would you mind noting that I asked about additional testing and that we discussed monitoring this for now? And then I think when you ask that, having it in the chart can help you and say, well, we asked about this earlier. It's in my chart. That's on record.
Yeah, at future appointments, it can jog their memory too. Like, oh, okay, well, it's getting worse. Well, maybe we can try what we previously discussed as next steps.
That's right. Or if you switch providers, there's your notes in there that show, okay, well, they talked about this. Let's see if it's something we need to do now.
Yes, agree. Kim, have you ever had to learn how to stop minimizing your own symptoms before going into an appointment?
So I've learned something from my kids. Every doctor appointment that I take my kids to, I've learned to let them speak for themselves instead of me speaking to the doctor. They know how bad it feels. They know the level of pain. They don't hold back when they're describing their symptoms. And so I shouldn't feel nervous going into my doctor or afraid to say, this really hurts or this really affects me. And so my kids have really taught me to just speak what's going on. And I love that about them. Like there's no sugarcoating it because they don't feel too timid in front of the doctor.
Yeah, I love that. Yes, we can learn from our children.
Some things.
Some things.
And like we've touched on, patients shouldn't have to do all the heavy lifting. So I guess next, let's talk about what providers in the system can do a little better. Sometimes patients don't need instant answers. They just need to feel heard.
And honestly, the best way for a provider to communicate and earn trust is, and this is my opinion again, look at your patient when you are talking to them. I understand you have to take notes, whether it's on paper or a computer, but know when to look at your patient and when to take notes. I mean, that is just simple, basic courtesy, is look at your patient when they're talking to you. And even, Lauren had a good example earlier. If you record them and get their approval, I think that's a great idea because now you can actually have a conversation with your doctor and they can look at you and hear what you're saying, or at least you can feel heard instead of them just, typing and looking at a computer. You're not really sure, like, are you listening to me? Because while they're typing, it's a very flat affect almost, and you can't really tell. And even the second thing I would say is even the smallest validation goes a long way. Say things like, I hear you, I can see this is affecting you, and we may not have answers right now, but we'll keep looking until we find something. But actually go and look for answers. Don't do like say that to Kim, like she said earlier, and then never get back to you.
That's right. And it's like what we teach our kids, right? Basic etiquette. Look at someone in the eyes when you're talking to them. Don't be on your phone or looking into space when someone's talking to you. I just had this conversation with my oldest, kind of teaching him how to advocate for himself with adults. And I'm like, just look them in the eye. It goes a long way.
It's so true. Back to the basics.
Yeah.
And what's one phrase that immediately makes patients feel safer?
I think that can be something as simple as just because we don't have a clear answer yet doesn't mean nothing's going on. We'll keep working through it. We'll find an answer eventually. I think just that one simple phrase can make a huge difference because it tells patients that the conversation isn't over just because the answer isn't obvious just yet.
Absolutely.
And Pam, what's one small change in how providers communicate that could make a big difference for patients?
I think it just all goes back to what we were just saying before. The nonverbal communication is just as important as the verbal communication. Look at your patients, like Kim said, it's just back to the basics. Show them you are listening and then verbalize an understanding as well. Actually look into ordering more tests, labs, imaging, whatever it is. But as a patient, Kim, how can a clinician create more trust when certainty isn't possible yet?
We've touched a lot of, on this, and it's just communicate and follow up. Pretty simple. I know doctors can't call every patient back with their findings, but say to them before they leave, let's set up another appointment to really take a deeper look at this. I'll make some notes. We'll research together. I don't have the answer right now, but let's really set some time aside to just dig into this.
Mm-hmm.
Right. Let's eliminate well, if it's not better, come back without an answer.
That's right. That's right. Well, here I am.
And that's what it all comes down to, right? It's just, it's just the simple things, the very small things.
Yeah, making that eye contact and saying, I hear you, I'm not giving up on you. I think that's mainly what patients want to hear.
Mm-hmm. Right.
If there's one thing I hope people take away from this conversation, it's this. Most of the time, this isn't about people not caring. It's what can happen when a rushed healthcare system meets someone who's scared, vulnerable, and just trying to understand what's happening in their own body.
Patients deserve to be heard, and providers deserve systems that actually allow them to listen.
Exactly. And Kim, thank you so much for being here today with us and for being willing to have such an honest, open, candid, and real conversation with us. We really loved having you on Bottom of the Scrub Bin.
Thank you so much for having me, both of you. This has been a great experience.
And to everyone listening, if this episode resonated with you, make sure to download, subscribe. I can't say that. And share it with someone who may need the reminder that they are not crazy and they're not wrong for asking more questions.
And we'd love to hear from you too. So if you have ever had a healthcare experience that really stayed with you, for better or for worse, was there something a provider said that made you feel really supported or maybe left you with more questions? Because whether you've been on the patient side or the provider side or both, these conversations do matter. So thanks for hanging out with us. Go grab yourself some more coffee, and we'll see you next time on Bottom of the Scrub Bin.
Thanks for digging into the Scrub Bin with us. If you enjoyed today's episode, hit follow so you never miss what's next. And as always, stay real, stay kind, and stay curious. We'll see you the next time. Bottom of the Scrub Bin is a podcast produced under SafeQ Solutions, LLC. The views shared reflect our personal experiences and perspectives and are not intended as medical, legal, or professional advice, nor do they represent the views of any client or partner.